So I only have, I thought this had to do, I don't think there's a lot of controversy with regards to intertrochanteric femur fractures, despite Emil's excellent video yesterday of perhaps we should be using more dynamic hip screws or sliding hip screws. But I think there's not a lot of controversy in how to fix an intertroch. The controversy, I think, if there is one, comes into what about those certain intertrochs where there's so much comminution proximally, that lateral wall's off, there may be a crack in the neck, plus the intertroch, the lesser's off, and the patient's active. Do you try to make chicken soup out of chicken shit there, or do you just go to a replacement? And so I think that's somewhat of a controversy, at least for me. So do we try to fix it or replace it? And then it's a bloody mess, and I'm going to show you a bloody mess when I choose to replace these. I generally need a Calcar replacing stem, so therefore I also cement them all. I try to reconstruct the greater troch, the lesser troch around that to reestablish the muscle forces around the hip. That can be a quite challenge. And then I'm usually at this place, if they're at this place, I'm using a bipolar as opposed to a total. I guess that's a controversy as well. And then there's always there's some guys in the community where I work where they're using unipolars as opposed to bipolars as opposed to totals. I was never trained with a unipolar. I've never seen anything bad. I've never seen anything work. I've never been referred to a unipolar that a patient was happy with. But they're sending them to me for a revision. You guys using unipolars? You got a pretty good experience with unipolar?
Very good experience. I have a senior, I'm like about 4 but I based it on life expectancy.
So how if I get a unipolar, how long do I have?
Right, exactly. But if they're really frail, it saves those systems some money.
Yeah. So if they're from a nursing home and yeah.
But if they're the pickleball playing,
yeah. Then you go with a bipolar, you go in a total. How good they are at pickleball? What's it?
I guess there's a grade
yeah. Yeah. It's not easy, is it? I mean, and the families always think these patients are rocket scientists, are ready to go up in the shuttle and all that jazz. And I'm like, she can barely walk across the room. Oh no, grandma's really good. I'm like, really? How come she's got sores on her heels? Anyway, all right. So those patients that I choose to do a total for an intertroch, it's a bloody mess, and I have a bunch of red slides here to just convince you. So the shaft in this bloody mess is down here. This is proximal, this is distal. I'm just trying to find my way through these bony fragments. I got my finger under what I think is the bigger part, the greater trochanter, I think is outlined here. And now we've exposed that joint. We use a corkscrew. Here's my corkscrew going in. Here's the head coming out. And I'll tell you, once you get the head out, then you're golden. You got plenty of visualization of the acetabulum with the greater troch off and the lesser troch off and the shaft. Now it's the simplest replacement there is. Broaching, this is important. Now that you've pretty much lost all your landmarks with regards to the lesser trochanter to greater trochanter, it's essential through a posterior approach, of course, to get that leg straight up and down, perpendicular to the floor, or perpendicular to the floor, so that you can put your broach in with the proper amount. And I put a little bit more, and I have the luxury here, I put a little bit more anteversion on that stem. Cleaning out the canal, there's no question you got to clean the canal out. You got to get all those bone marrow contents out. You got to flush this thing until it's crystal clear. Bill Maloney convinced me it wasn't the PMMA that was killing my patients. It was the fact that I wasn't doing a good job of cleaning out the canal. So I really scrub the canal. I get all the marrow contents out of there. I wash it until the fluid's clear. I always bring the anesthesiologist into the room. I don't, the CRNAs could sometimes give me a little crook eye there, but if I'm going down with the anesthesiologist in the room. Patient's going down, I'm going down with the anesthesiologist in the room, and not just the nurse. So clean it out really good, irrigate it really good. Then I put my cement restrictor in, and yes, I put a cement restrictor in. I use third generation cementing techniques, and then I wash it some more. At special surgery, we used to pack the canal with a gauze soaked in epinephrine. I don't do that. Anybody still doing that? No. You try to dry the canal, but while they're mixing the cement. So then we got the canal cleaned out really well here, clean and dry. Anesthesiologist in the room, cement restrictor. You got to be careful. Some of this bone is pretty wimpy, so I cut into the cement restrictor so it goes down a little easily. I measure it. I measure it versus the trial, or actually the component. I put a circumferential mark where I want it to be. I put it in there, and then I still check. I push the trial in or the component in to make sure it's down far enough. And at least in a humerus recently, somehow I didn't put the restrictor down far enough, and realized that when I tried with the broach, the trial. Make sure that canal is nice and clean. Go ahead and cement. I use an antibiotic-containing cement. And then as we're press fitting the prosthesis, again, keeping the leg perpendicular to the floor in a posterior approach so you dial in enough anteversion. Lengths, that's a struggle a bit. I use a collared prosthesis, or at least I did until the Avenir cemented one, no longer collared. So I try to trial a prosthesis. I sometimes use a standard reduction forcep around the neck of the prosthesis just to maintain a little length, do a trial reduction. In this case, I measured where it should be based on preoperative measurements, but even then, I usually, if I err, I leave it a little proud. I'd rather use a minus 3.5 head than not have a 12. So I'd leave it a little proud, but.
You got them posterior, so do you try to match the other leg?
Yeah, I developed a little technique. I don't know if it's caught on yet, but maybe this is a good form to. I put cardiac leads. I put one on the patella of the down leg and one on the heel of the down leg, so that I can more easily feel for it intraoperatively. And the anesthesiologist thinks I'm nuts, or the CRNA, I'm asking for a couple leads, but my staff is into it, and I think it's been really successful. You should try it. Just a cardiac lead on the down leg, the non-operative leg, one on the patella, one on the heel. I make sure when I tape it down, I don't cover it up with the blanket, and I can feel it through the drapes.
Yeah, that's good.
Feel free to reference me. I got to figure out how to market that. Anyway, yeah, length is important, anteversion's important, and then reconstruction of the soft tissues around. Some of these slides show the wires being passed through or around the proximal femur or through the lesser if it's still on. I don't know if you're familiar with building up that calcar, 10 or 20 millimeters if you need a little length underneath the collar. Bring those wires out around the proximal femur before closing the book, before bringing the greater trochanter down on top. Actually, you got to reduce the head here and then bring the pieces back down around. This is a technique I've used in the past. I don't use it every time, but some of those cables or wires will cut right through the gluteus or cut right through the bone. And if you can carefully put a couple 2 OK wires from the tip of the greater trochanter to the lesser, or to the medial cortex without going too long. Then you can wrap the wires around those as well, and they provide a little bit more purchase for you to restore that greater trochanter. That's what we're doing here. And use that interval between where the K-wire comes out of the bone to put the cable or put the wire to hold that piece down, rather than have it slide down, and tighten it up, or crush the bone as you go into it with the tensioner. And then you can, in this case, we're using wires instead of cables. You just twist them a couple thousand times, snip them off. I love this little, this is a AO pliers, where it has a little notch here. And if you put has a little notch here, this is a cutter. You put a little notch here, gets you to 90 degrees to 100 degree bend, and then it's easier to complete it to 180 without snapping it off. I like that a lot. I use that a lot for the olecranon fractures. And then bend it around and tap those around the cable or around the wire into the tip of the greater trochanter, as you can see here. And here we are tapping them down into the greater trochanter. And then hopefully you end up with something like this. Here's where those K-wires are coming down to the tip of the proximal femur, lesser troch if you still have one. The cables or wires are looped around it, just like a tension band for the old way we used to do olecranon fractures, or the old way we used to do patellar fractures. But I think this is a good way to go with some of these real comminuted intertroch fractures that are going to look like crap if you fix them, and 3 months later, then you're coming back to a stiff hip and you're trying to replace a hip. Otherwise, I don't think there's a lot of controversies with intertroch fractures.
But I'm sorry, Joe, I fell asleep for a second, but I'm awake now. Why do you say that this won't heal? I mean, these don't do, I mean, it's not like a femoral neck fracture. These will heal.
Yeah. But they'll heal some of them will heal, you're right, and it's a hard decision to make, but some of them will heal with so much shortening that the patients are miserable. The DHS is designed to shorten. If you don't statically lock your TFNA or your gamma nail, they'll shorten. And then you have a massive healed intertroch, but it's short.
I guess I just haven't seen that many problems with them, and maybe you're right, I'm not letting them kind of settle much, but at least some of the literature, and I think that's from Bowen and Dari, it said it can shorten up to 3 centimeters without too much trouble. I agree with that, but I don't feel that my intertrochs are shortening that much, or that I don't have any problem doing it. You did great with this, but I'm not sure I'd jump on that from the beginning.
No, I think it's a tool to have in your armamentarium. I don't use this very often. It's a bloody mess. But on some, I look at the X-rays.
Looking at your case, I was like, that's what got me a little sick. I'm like, why
Yeah,
did you do that to yourself?
no. It's you get a CT scan and there's more pieces than you wish. Patient's pretty active, but they're smashed. Andy, you have any experience with the Calcar replacing?
Yeah, I used to do them exactly like you did. More currently, when I have these sort of fractures, I've been using an uncemented fluted, tapered fluted stem.
So like a Wagner?
Yeah, exactly.
Modular or unipolar?
Non-modular, yeah. You can, just avoid and by definition, you're using longer stems for these, and I just hate cementing down the whole femur if you ever have to do a revision. But I've had good results with those. It's a similar stem we use for revisions now in almost everything. And but the cases are fairly few and far between.
Yeah.
Back when we used to fix these with compression hip screws, again, I mentioned to Kyle earlier, he had the Kyle 5, kind of modification of his intertroch classification where there's an associated, basicervical fracture. And you can see those like this, or even these really badly comminuted intertrochs. But when you see that fracture line where the head and neck are kind of a separate fragment, those are the ones that are really hard.
Yeah.
With a cephalomedulate nail, it's really hard to avoid pushing that fragment over into varus.
Yeah.
You almost have to provisionally pin it or joystick it or something to, or purposely ream into it, before you start going down the shaft, because otherwise the nail just pushes it over.
Yeah,
And,
there's
you know,
some,
varus-
I think this is a good technique to know how to do.
Yeah, yeah, so if you've got a case like that, or, but again, the patients are so frail and, you know.
Right.
But the point is that tapered, long tapered fluted stem gives you good fixation.
Everybody pretty familiar with the Wagner? Yeah.
Yeah, so I think that's,
Especially you got pretty good cortices to dig into. Yeah, good. All right, thanks, Andy. Any other questions, comments, cases? Yes, sir.
Any comments on reverse oblique fracture?
Yeah, I think we covered that yesterday. No, that's right. To get them reduced. To get them reduced.
Putting a nail in it, sometimes it's reduced when you try to drive a nail in this place.
No, you gotta either hold the reduction, or I'll put them on their side and open it, like we did in the lab yesterday. I'll put the patient's lateral, open it up, reduce it, put a cable around it, and you know, I was trained 30 years ago, the AO technique, you never put cables on anything. I think in the proximal femur with a reverse intertroch, get it reduced, get it either held or permanently held with a cable, and then put your nail down.
And I think the other thing that we don't use enough, and it's in reverse obliquities, is those polar screws. If you put your nail in and you start kicking it into varus, just put the screw where you don't want your nail to go, and it actually is a great way of holding your reduction while you put the nail in. I think the key is to recognize it's going into varus, just back up the nail, and then put your polar screw in.
Yeah, so that polar screw that Dr. Dixon's talking about is right at the base of the neck, just proximal to the lesser, where the fracture is going to start before it goes out laterally and distally. It's not as easy as you think. Personally, I would reduce that lateral cortex, which is, you're looking right at it underneath the vastus lateralis. Hold that reduction either temporarily with a reduction forceps or a cable or two, and then put your nail down. And then leave the cable on there. Don't take the cable off.
And the cables, you know, and I agree with Joe, a lot of times, the most common problem that I see that's sent to me is it's kicked up anterior. And the cable solves that problem too, because there's a nice spike there.
Yeah.
You just squeeze it down and you just leave the cable on. But you still may need a polar screw because it still may kick it a little bit.
Yeah, the case I talked about yesterday where I had the patient laterally and had a collinear reduction forceps that I snuck across the anterior proximal femur and clamped it down. Fortunately, after we got the nail in, it stayed there because eventually you got to take the collinear reduction forceps off. I'm not crazy about passing a cable if I'm in a lateral position because bad things can happen, but you could theoretically keep the tip of the passer on the bone, go around the back of the bone, put a cable in and take that collinear. It takes a little bit of an incision, but you're right. It's much better than allowing it to tip into varus. All right?